Good morning and welcome to the latest in a series of webinars focusing on innovations, ideas, and efforts to support condom programming. Let me put my video on here. It's great to be with friends and colleagues from the South to South Learning Network again. I know that many of you will be gathering in person next week for the SSLN Champions meeting. And we've designed this webinar to seed conversations which will continue during next week's deep dive into condom programming. So we look forward to seeing many of you in person, finally. A few months ago, we met to discuss innovative methods to support the gathering of data and evidence to inform decision-making, including presentations that highlighted techniques such as ballot box initiatives to track and understand condom use behaviors with focused populations, and crowdsourcing to understand market access. And today, we're going to focus on new efforts to support last mile distribution in an effort to increase access to condoms. So first, and Yanni, could we advance to the next slide, please? Some context. Looking at this slide here, evidence shows us that it's more than just distribution that leads to use. The slide we're looking at demonstrates quite a broad range of condoms distributed, which is measured on the y-axis as condoms distributed per capita, and the correlation to use measured on the y-axis in sex with higher risk non-regular partnerships. So taking a closer look, the band of countries in red in the middle highlight the disparity of condoms distributed from a low of about 8 condoms distributed per capita in Nigeria to nearly 20 condoms distributed per capita in Uganda, all to support similar levels of condom use. So in other words, while condom distribution is obviously important to support use, distribution alone, getting them out of centralized warehouses, doesn't directly translate to access and therefore use. Too often we see that distribution that relies on clinical facilities as access points means that those condoms are out of reach for populations that don't want to or desire to go into medical facilities to pick up their condoms. Those same populations, such as sex workers and MSM and youth, also happen to be at highest risk of HIV. So distribution does not translate to access, although it is obviously very important. And I also want to just note that clearly there are factors such as demand that play an important role in ensuring use. It's more than just making sure that we've got condoms that are accessible and available, but we want to be sure that we're addressing the behavioral components of condom use that are just critical to ensuring uptake and actual use of the products. So today we'll hear from programs that are making an extra effort to ensure distribution extends beyond medical and clinical facilities to create access for condom users in bars and hotels, restaurants, and busy community locations, all places that are a bit closer to where condoms meet, sex is discussed, or even takes place. So we often call this or refer to this as post-facility distribution or distribution for the last mile. So first on our agenda is Washington Ozituosauka and James Njobvuyelema, and I apologize for butchering your names, from the national program in Malawi, who have developed a new last mile distribution strategy that is just about ready to be launched. It's good, it's thorough. I encourage it to be shared and reviewed. The Malawi team have taken a methodical approach to support access for populations where and when they need condoms. So we're going to learn a bit from their experience in the early days of this effort. We'll then hear from Ivan Luswata from the Joint Medical Store in Uganda, who is in partnership with the national program, reinvigorating an approach leveraging USG and global funds through an alternative distribution mechanism that relies on non-human dispensers. They'll share their experience in mapping and lessons learned and building on a lot of work that's taken place in the past and really which is a reinvigorated and new effort in Uganda. And then finally, Isidio Nantomba of the CNCS or NAC in Mozambique and Jose Neves of Project Last Mile will describe an innovative public-private partnership that leverages commercial and non-commercial outlets to extend reach and availability. So I do encourage us to keep it interactive. Please do send questions into chat. We're going to make sure that we build in time to have a discussion, ask questions, and also, again, as I said, seed conversations for next week in person for the meeting in Nairobi. So with that, I will hand it over to Washington and James from Malawi to share their experience with developing a last mile distribution strategy. Washington and James, over to you.
Thank you. Welcome to our presentation on enhancing condom distribution to the last mile. Just to say that the Malawi team, our coordinator is Dr. Andrina Masambo, who is the head of HIV prevention at the National AIDS Commission. She'll be joining us soon. Apparently she's traveling, so wherever she finds the network is okay, she'll join us. So I'm starting the presentation on behalf of the team. We have Washington and Betha, including Joa for UNAIDS, who are from the Malawi team. So you can continue to the next page. Okay. Outline of the presentation. I will present on the summary of the situation analysis that we conducted prior to the development of the last mile distribution strategy. So focused on the condom access and use, condom market share, condom supply. Thereafter, I'll come with the overview of the strategy, which has objectives, strategies. There's a flow chart just to summarize everything, and priority geographic areas, and then the implementation, the roles of different implementers in the strategy. Next. So as a matter of introduction, I'll bring the situation analysis, this time focusing on the condom access and use in Malawi. So we observed that the poor access is frequently associated with lower use. So because of poor access, there's lower utilization of the commodity. So access variation among priority populations, we have data that shows that there's an improvement in terms of access and utilization among key populations. That's female sex workers and men having sex with men. But we still have issues and challenges with the adolescent girls and young women, including the male counterparts. Next. So I went to the Malawi Behavior and Biological Surveillance Survey that was conducted in 2019 to 2020. We found that female sex workers, most of them report that it is easier or somewhat easier to access condoms. As you can see, the green bar at the end, almost 67 to 0.8. We found that accessing condoms was very easy. And the other percentage, somewhat easy. But we still have 7.9 who are still finding very difficult. Just to explain the situation, when we started implementing the key population programs, we also introduced prior distribution of condoms to the key population. So the mainstream condom distribution that goes to the health facility was still being used, but specifically for the key population, there was prior distribution system that was being coordinated by our partners. They were getting condoms from central level and straight to the DICs, where those drop-in centers where we have the female sex workers. So they were accessing from that side. That's why with time, they found it very easy, because when they go there, they get the condoms. Whenever they're in the hotspots, they have condoms in their household bags. So when the client doesn't have a condom, they usually fish out the condom from the book, the one that they got from the DIC. But with time, we are integrating the systems, but still, this access to condoms for key population has greatly improved in Malawi because of the projects that we're implementing on key population. The same applies to the next slides. Next slide, yeah, where we have the male sex workers. They also get the condoms through their peer networks, through the biosystem. the projects that are being implemented, support from PEPFAR, Global Funds, and other partners. So they find it easier to get the condoms. But as you can see, there are still some who haven't come. They're still finding it very difficult to access the condoms. This is because they don't associate much with their peers in the DICs and other corners that they meet. So we still have issues, but at least the percentage is low. Next. Now, on adolescent girls and young women, based on the study that was done by World Vision and the University of Manitoba, that was 2021. It's a different story as compared to the key population. HYW reporting lack of availability as a reason for not using a condom in the last 12 months. So after they were asked about why didn't you use a condom during the last sex encounter or the sexual practices that have happened in the last 12 months, and most of them, as the graph is showing, they reported that condoms are not really available to them. So that's why they don't use condoms. So we have a large gap in the adolescent girls, and this applies to adolescent girls and the young women, including their male counterparts that are in the community, out of school, or those that are in school, like higher education facility, institutions. Access to condoms is still an issue. So next. We also analyzed in terms of the condom access and use. We also asked the frequently discussed factors of use, which, as discussed earlier, there's an issue of poor access. The condoms are not easily accessible in some geographical areas, as well as for some population, as I mentioned, HYW. Gender norms, especially the females are disadvantaged because negotiating for use of condoms during sex is also an issue. It's the male who is mostly empowered and has cash, and they can decide or dictate whether to use a condom or not. So the other gender, that female gender, is mostly disadvantaged. Stigma. You can agree with me that there's still stigma attached to condom use, because the use of condom is associated with promiscuity. So imagine you are in a shop, you are shopping some groceries, and then you ask for 3 condoms, or the people on the queue think this guy or this woman, why is he buying condoms? So stigma is still an issue in terms of as a barrier to access to condoms. And low risk perception. Despite accessing condoms or having condoms around, but if you feel you are not at risk, you are not. If you feel you are not at risk, it means you are not going to use the condom. So mostly some people they don't use condoms because they don't feel they are not at risk, for reasons not best known to themselves. But it's an area that needs to be explored further. Issue of education. The surveys that we have conducted, for example, the demographic and health survey, found that condom use is high among unmarried young men who completed at least primary education than those with no education. So you go with education, at least you understand that the condom is also a use of HIV prevention method. But with low literacy levels, And in our country, there's high illiteracy level. So this affects the utilization and uptake of condoms. And there was this study that we also referred, where it was found that safer sexual practices influenced more by other factors such as relationship dynamics, fertility temptation. For those who want to have children, even if the condoms are around, they have access to condoms, but you want to have a child, you want to have a baby, it means you're not going to use a condom. This is used commonly with the married couples or even people in relationship. So it affects condom use. And safest case, if you feel you cannot negotiate for condoms, you cannot use a condom properly, you are not sure how to use it, you are not confident, so it affects your intention or to use a condom. So these are some of the issues that were found in this study by Haddad. We also consulted for this document. Issue of convenience, distance and location associated with obtaining condoms from outlet is an important factor to access and utilization, especially in hard to reach areas. The condoms are not easily accessible because you find condoms at the health center and you're staying some kilometers far away from the health center. You want to use a condom, but they are not there. Next slide. And the issue of common market share in Malawi. As you can see, 68% are public condoms. These are free condoms. And social marketing only accounts to 30%, and commercial condoms 2%. So what it means is that, this 68% public condoms, free condoms, mostly in Malawi, they are procured by donors. We have Global Fund procuring almost over 90% of these condoms, and then the other partners like UNFPA. So if there is over-reliance of these donor procured condoms. So it means as a country, we are in a situation whereby when the donors just move out, we remain with the 30 and the 2. So what we want is this 30% should increase. At least 30 and 2 should increase, because by using these socially marketed condoms, at least you pay something. And what it means is it's a commitment from your pocket. So if people start using to use social marketed condoms or commercial condoms more, it means even if the donors are pulled out and for somebody to make a decision to buy a condom, it means there's behavior change taking place. So we want at least to move the 30%, at least there should be a fair share of these of the market, not just relying on the public free, which are donor dependent. Next slide. We also looked at the supply side, where we found that most public sector condoms are distributed and accessed through health facilities. So while condoms are available at the health facility level, access has been a major barrier for some focused population and geographical location, particularly in hard to reach areas. So if condoms are only found in the hospital, others are staying away from distances from the hospital. And also there are some population groups, due to some stigma and other issues, they can't easily access the condoms. Like the key population, we are talking of young people where there are no youth-friendly health services. It's very difficult to access condom from this facility from a health worker, because others, they be judgmental to them. And so limited condom availability at the community level is mainly attributed to challenges in distribution. Supply chain systems in the public sector are improving in Malawi, but there's often a significant gap in ensuring condom distribution beyond health facilities and target distribution to focus population. So much as we have condoms pushed to the health facility, but to take the condoms beyond that facility, it requires community systems, because not everyone will go to the health facility to get a piece of condoms. We need to have systems, mostly PLA systems, where somebody can just get a condom within reach. So supporting availability in non-traditional outlets is key towards addressing iniquities in condom access. So this document that the guideline that we have developed, we have included non-traditional outlets, not just through the health center, through the HSS, through the health worker, but we want other innovative approaches to make the condoms available at community level or to end users in hard-to-reach population and geographical areas. Next. So just an overview of the last mile guidance or strategy for Malawi, which is currently the final draft and is awaiting approval by or endorsement by the Ministry of Health. Some implementers have already started using it, like the Global Fund. You know, the project is time sensitive, and in our case, it's being implemented by World Vision. So they were given okay to start implementing using the guidelines. Primary objective of the guidelines to expand access and utilization of both male and female condoms, including lubricants, to high-risk populations and some populations at risk of contracting HIV infections. Next. So specifically, we want to increase condom distribution points to underserved populations, communities and hard-to-reach areas using innovative approaches. We want to increase access and uptake of both male and female condoms among high-risk population, focusing on high-prevalence geographical areas of the country. I'll explain what we mean by high-risk geographical areas in our country. We want to establish or use the existing community formal and informal structures within the and outside health system to support condom distribution to last mile. We want to monitor availability and consumption of condoms at all levels. So these are the specific objectives. Next. So these are the strategies. One, community-based distribution. Door-to-door through community-based distributing agents and peer educators. Already we have community-based distributing agents under the family planning program who are trained to distribute contraceptives, and in some cases they also provide HIV testing, especially the self-test kits. So we want to integrate the condom distribution in these existing structures and train more. Use of peer educators, community home-based care volunteers, CPOs, these are community-based organizations, and even bicycle taxi operators, market committees in the informal sector. We want to reach everyone in the community. To also leverage other government frontline social workers and extension workers. In the community, we don't only have health extension workers. In our case, health extension workers, we have health surveillance assistants, but other sectors also have extension workers, like agriculture, they have their social welfare, they have child protection workers, we have youth department, which has also extension workers, community development assistants. So we have several line ministries with the extension workers. So we want to, because these are always in contact with the community. So we want this to leverage their availability, also to orient them, and then they should be condom distributing agents as they do their day-to-day work. Non-human condom dispensers, We want to place them at strategic points within the communities, tertiary education institutions, markets, border posts, uniformed forces institutions, bus depots, restaurants, and other strategic areas like hotspots. So in terms of tertiary education, we have already started, like at National Health Commission, we already started installing this tertiary, this condom distributing and human condom dispensers in the tertiary education institutions after we noted that there was critical need for condoms, but access was an issue. Next. So I want to align to the total market approach, whereby we have the public distribution system, we have the social marketed condoms, and then commercial marketed condoms. So we want to consider last mile distribution innovations for social and commercial sectors. That will be discussed later, but for now, we have focused much on the public sector condoms. Next. Just a summary in this diagram, or a summary of what I was saying. So the condom distribution flowchart will be like as follows. From the national level, condoms, just like any other health commodity, they are distributed directly to health facilities, of which in our country we have close to 800 health facilities. So from health facility pharmacy, then going to the left-hand side where we have facility distribution, which is the one that is currently in use from the facility. So condoms will be issued at the facility, and then documentation, there will be dedicated requests and issue vouchers for the facility. This is where we get all the data for reporting in our M&E system. We get from this dedicated request and issue vouchers. From there, the condoms will go to facility healthcare workers and the facility distribution points. So at facility level, we have several outlets for condoms. For example, one can get it from the dispensary, one can get it from the ART clinic, one can get it from STI clinic, family planning clinic, OPD. So all those facility-based distribution points would be considered. And then the other arrow is pointing on the community distribution system, which we are now focusing much on with the last mile distribution, whereby from health facility, we go to, in terms of documentation, we issue a dedicated requisition and issue voucher for a community. So that one will be issued. From there, we have health surveillance assistants who are extension workers for the health department. So from these health surveillance assistants, we go to now to condoms in the last mile. It's now the health facility assistant. Mostly a health facility can have a catchment area of maybe 20 villages or more. So each of the villages, or 2 per village, will have a health surveillance assistant who does the primary healthcare issues like immunization, water and sanitation, and other programs. So we also use them for the HIV program. So these are the people who are maybe 1 or 2 villages. So they'll get the condoms from the facility. And then from the facility, we go to the first arrow on the left is the volunteers. So these volunteers can be expert clients. Expert clients are the clients who are HIV, especially women who are HIV positive, and they have been program for so long. They are mentors, especially the PMTCT program. They are mentors on mother-child pair follow-ups. So we use these people also as for distribution of condoms. We have CBDAs, I already mentioned about them, and HIV safety distributors. We also use them for the distribution of condoms. And on the middle, we have community structures who are village health volunteers, village nutrition volunteers, committees, village health committees, there are immunization committees, family planning committees. So we leverage on their availability and then also orient them so that they should be distributing the condoms. And we also have committees and associations, like in the formal sector, we have market committees, taxi committees, business institutions, stakeholders. Through these established committees, we'll also be able to use them for distribution of the condoms. So reaching out to the target population, who are the key population, high-risk clients, and hard-to-reach population. So this was just a summary of what I've presented in the previous slides. Next. So in Malawi, we are saying we have 28 districts, but for this last mile distribution strategy, we know that condoms are required by all the districts, but in this we'll focus on the 17 districts and cities regarded as geographical areas with high new HIV infections above average incidence. So the next slide shows a figure, a graph where we have all the districts in Malawi, but the light green shows the districts that have above average HIV incidence. So while the national average is 0.17, we have others as high as 0.4. So these are the areas where we focus the last mile condom distribution, while maintaining the pace in the dark blue colored districts. Next. So in terms of roles, we have Ministry of Health, who provides the overall leadership, policy direction, and oversee the implementation of the last mile condom distribution. And National AIDS Commission, who first on the sectoral coordination. As you can see, this initiative involves a lot of sectors beyond just the Ministry of Health establishment. So NAC, we are responsible for the coordination of the multi-sectoral response. So we'll strengthen this role in the implementation of this strategy. And also monitoring. We monitor through organizing the reviews through the TWG. So NAC organize those TWG. We have the condom coordination, National Condom Coordination Committee. We have the prevention TWG that we anchor. And also at district level, we have prevention TWG at district level. And also we have a condom coordination committee at district level. So it's the role of NAC to make sure that these sectors are well coordinated, and we reporting of condom programs or projects and monitor how they are faring. Also conducting periodic monitoring to the implementers, as well as doing the evaluations, like I presented the PBS, which is anchored by NAC, and other studies that we do. Global Fund, as I said, is funding a very large portion in terms of condoms in Malawi. We have USAID and PEPFAR and other implementing partners. We have UNFPA. So They will also be key in the implementation of the last mile within their respective program districts, where they have a lot of implementing partners doing HIV work. So they will be also align their projects to the last mile condom distribution strategy. We have World Vision, which is currently rolling out the strategy in 5 districts, mainly focusing on adolescent girls and young women. Our colleagues from PSTI and BOM, these support us in social marketing. So as I said, we want the last mile also to consider the elements, the area of social marketing and commercial marketing. So these are the experts as in Malawi. Next. Ziko Mokwambili, thank you.
Thank you so much, James. Just to highlight a few of the attributes of the Malawi program that I think are worthwhile of sharing. And James, if you were able to share the guidance, or we can share that with the SSLN distribution network, once it's finalized would be great. But just the fact that Malawi is focusing on geographic prioritization. They're not trying to do everything everywhere, but they're focusing their resources on those districts that are highest in incidence and driving the epidemic. They have supported systems, identified systems in place to support the plan. That includes distribution as well as monitoring and evaluation. They have clear partners in place to support with identified roles of each, which is commendable. And also they've got funding to support this effort. The work of Global Fund and PEPFAR jointly to come together to make sure that this plan becomes a reality is commendable. So thanks so much, James, for sharing your experience. I'd like to move on to Ivan from, and we hope to have some time for Q&A as well. So again, keep the questions coming into the chat. We'll be able to address them as we move forward. Up next is Ivan from the Joint Medical Store to discuss last mile distribution in Uganda. Over to you, Ivan. Thank you.
Thank you so much, and good evening, everyone. I'd like to thank the team for the opportunity. I'm here to give a brief about our experience in conducting last mile condom distribution, the history, because we've just finished the initial phase. And the presentation, we shall just give a brief background about condom programming in Uganda, the objectives of the programming, the distribution mechanism, or the supply chain mechanism of condoms in the country, then the methodology we used to handle the last mile distribution, and how it impacted on the consumption trends of condoms in Uganda, the achievements so far we've been able to gain in this condom distribution, and the challenges we faced, and how we are proposing to move forward to ensure that there is unlimited access to condoms to every Ugandan that needs them at any time. Next slide, please. And when we look at it as a university in Uganda, an approximate of 250 million condoms are needed in the country. That is to protect the entire people that do sexual acts 100%. But from the 2020 data, we only issued 170 million condoms that were distributed in 2021. And the available data based on the studies done show that of the condoms distributed, only 71 million condoms are put to good use. The difference indicates due to the high wastage and major gaps regarding data use that relate to that. But maybe that one will be a study for some other time. Next slide, please. So briefly, Uganda is one of the countries that are doing their best to fight against the higher HIV prevalence, which is current at around 5.5%, the high teenage pregnancy in the country of school-going girls, which is around 25%, high prevalence of people reporting with STIs of 24.4% in women and 13.6% in men. So given that the condom provides a triple protection, it is keen preventing the HIV infection, the pregnancies, and STIs. And and Ministry of Health, together with UNFPA, initiated programs of the ADS to ensure at least there's unlimited access to condoms, both male and female, to all people that need the condoms at any particular time. And currently in the country, all condoms distributed through the country, majorly go through 20% go through the public sector, and 80% go through the ADS alternative distribution system or mechanism that is managed by Joint Medical Stores, the organization I work for. Next slide, please. So Ministry of Health introduced a condom programming unit in the Ministry of Health that is responsible for monitoring condom use in the country. This condom unit came up with the condom logistics management information system that was introduced for the alternative distribution system together with the UNFPA support in 2017. And it was piloted among the different partners. That is the different partners in the country to be able to account for the condoms they use and how they can be able to use this information to quantify better for the actual need of condoms in the country in Uganda. So for us as Joint Medical Stores, we signed a memorandum with the Ministry of Health to warehouse and distribute these commodities in 2008 across the country as the leading implementing partner for the alternative distribution system. And since 2019, the Condoms management information has evolved and modified across the supply chain to be able to capture data to ensure that we use data that is relevant to condom consumption in the country, and hence how the hotspots are used, hence the last mile condom distribution and GIS hotspot mapping system. Next slide, please. And basically in the country, we have two channels of condoms. That is the donor-funded condoms. That is nationally, they come through to warehouses, the national medical stores, which warehouses and distributes condoms to public health facilities. And the alternative distribution warehouse, which is managed by Joint Medical Stores. This one distributes condoms to the different implementing partners, emergency orders through the districts, to PNF-PFA facilities and PFPF facilities. And then there's a non-traditional mechanism which is introduced, which is the last mile condom distribution, exactly to the condom hotspots. And also to some other public sector suppliers, that is ministries and agencies. The social marketing and the commercial condoms have their own arm where they don't go through the normal channel, they go straight to the market where the market is, and they distribute condoms direct to the different clinics, pharmacies, supermarkets, anywhere where people can get it. While the public sector, people get the condoms through the public health facilities, while for the ADS, people get them through the PNFP and PFP facilities, but there is this need where we have introduced directed to the last mile, direct to the condom hotspot. And in this case, a condom hotspot is a place where consumption of condoms is high and where they are needed. And these places are equipped with condom dispensers. So initially, from this other non-traditional means, condoms in this place, people in these hotspots didn't have sufficient condoms because there was no system of routinely refilling hotspots with condoms. So they would rarely depend on district IPs who will fill condoms as of when they get funding. So to reach the point where health facilities had enough condoms and very few people would go straight to the health facilities for condoms, yet the hotspots where the actual need actually is, people didn't have these condoms. So GMS, we came up with this initiative of last mile distribution together with the Ministry of Health and the Condom Programming Unit to ensure at least there is routine supply of condom to the hotspots, such that the person who needs the condom gets it as of when they need it. Next slide, please. So the objective was to increase availability and accessibility with adequate timely condom logistics at community level, and it contribute to operationalization of people-centered and data-driven condom programming in line with the national strategy of 2021-2026 to strengthen the condom logistics, data management, and accountability up to the community level, such that people own the information that comes through that will enable the country to plan better for the condom needs in the country, to generate evidence for effective scaling up over the whole country and target population hotspots, and to improve on the accountability and traceability of condoms across the supply chain. This one also will envelop to account for wastages that have been happening across the supply chain, and to develop a tool to be used by Ministry of Health and partners to conduct last mile assessment. That means to know that if all the condoms are distributed, how are they used in the country, and do they actually use the adequate beneficiaries as to when they need them. So that was the major objectives for this last mile assessment. Next slide, please. So we used a method of stock hub distribution model, and in this method, where we move condoms from the different from our central warehouses to hubs, strategic location in given districts, geographical locations, and in this, GMS contracted a third-party firm which has different motorbikes that picks condoms from the hubs, from the distribution hubs that we've created to the different hotspots. And this NF2 was contracted leveraging on the fact that they have a system of border riders that is who use motorbikes across the country, and these people can give in jobs to the youth. So we use them, and they are picking the condoms from the hubs and refilling at the hotspots. And we give ourselves a target of 2 to 3 days of when the condoms are delivered to the hub, as in to control the logistics, the wastage, the cost of holding on the stock at the hub, such that the condoms reach the end user within 2 to 3 days. So this team has done a good work to ensure that at least they pick the condoms. And in the same method is that we went, given this was the first time we implemented this activity, we went on to do geographical mapping of the condom hotspots, in that we are able to know that District X has 10 hotspots, and they are located in these towns, that they can easily be geographically located, such that in the subsequent distributions, we are able to directly go straight to the hotspots and deliver. We did this together with the condom focal persons in the districts and the key implementing partners in the district. Next slide, please. And given the fact there was no consumption data, and it was the initial phase of implementing the last mile assessment, we resolved that every condom spots we identify and map it geographically, this location. It was given the same period, it's given only 1 carton of condoms, which is around 3,000 condoms for the first distribution as a baseline, upon which subsequent supply will be based on. And this phase ended in December last year, that is 2021. And the second phase has actually commenced for about 6 months to see us that we are able to establish the costs involved in this distribution. And in the future, after this second phase, we propose to a pull method where the hotspots are able to order directly from the central warehouse, and we just go delivery as their need. We plan to initiate an app where they can be able to also order from the same system. And in the phase 3 shall be determined by lessons and achievements from the phase 1 and 2 that we've been able, and it will be tailored on sustainability, linking this data from the hotspots to the Ministry of Health database and reporting system, that is DHIS2, and strengthening a full implementation of government structures to ensure that there is accountability and the visibility of all the condoms distribution through the supply chain, and to ensure that condoms reach the end user as of when they need them, and there is unlimited access to the condoms. Next slide, please. So in the activities that we are able to conduct is that we identified these hotspots, and we are able to map them out such that someone can easily see centrally and know where the hotspots are, and identified the people who we call them the hotspot managers to deal with and obtain their phone contacts. So there is that communication that can be initiated and fall back positions. Then also we developed a data management system to be used in the process to capture data on condom distribution, and also wanted to track data on the condom dispensers at the different hotspots, because the reports were coming in that condom dispensers were not functional. There are no condom dispensers, so we captured data on the availability of condom dispensers, and if it's functional, and those ones that don't have dispensers, such that this information can be used to obtain extra funding to ensure at least we get these dispensers well maintained. These dispensers are put to actual use, and we'll train people on how to be able to use these dispensers and how often they can be able to refill them based on the information that is available and expect. Also, we are able to collect that register regarding the status of the identified hotspots, because we had an initial list. We found some hotspots that closed and maybe new ones that opened. So together with the focal persons in the districts, condom focal persons in the districts, we are able to identify these hotspots and new ones and put them on this map and put them in the register. And at the same time, we did also distribute condoms, the verified mapped hotspots, and this was we are getting one carton, which is 2,300 condoms as a pilot, and let us will later on develop a schedule of how to be refilling these hotspots to ensure there is unlimited access to condoms at the hotspots. So this activity, we all began it by developing the system, which was done together with the GMS field team, the Joint Medical Swords field team that traversed the entire country to get this information and to identify the hotspots across the country, together with the district IPs and the Ministry of Health Pharmacy Department, Ministry of Health Condom Programming Unit that helped us in doing this activity. Next slide, please. So in data collection, we developed the system that I've talked about to capture the data as we distributed to the condoms of different hotspots across the country. And the system we call GMS NFT Mobility App, in that data is developed instantly as of when they are delivering the condoms, when they identify, they map, they capture details of the hotspot manager, geographical location of the hotspots, integrity of the condom dispensers, and also capture information of receipt and who will be responsible for the subsequent orders and management of the hotspots. All this information is now available, and the information, this information that was collected in that at the moment now we know which hotspots is in the country, who manages what, and we established an initial contact such that these people can follow us back and they say, you know what, we need condoms, and we establish a team that can be able to feed the hotspots to ensure the spots don't run out of condoms at any one point. Next point, please.
Thanks, Ivan. Just to note that we'll have just about 3 more minutes left for the presentation, just to make sure we have time for the others.
Okay, yeah. So now in this last mile distribution, we are able to observe around an increase in the consumption of condoms of around 30% only in the year 2020-21 as compared to 2020, which showed that this need was actually there and the initiative has paid results, and about 26 million condoms are distributed across this model, which we are able to impact lives in this category, and we are able to get this relevant information regarding the hotspots that will be used in hotspot mapping. So it paid off, and with subscription, we are able to see more consumption as of need, and people are really appreciating as communities. Next slide, please. And this shows you the different hotspots we mapped across the country. You can be able to locate which hotspot, where is it located, who's the manager. You have the contact, you can call and follow up. And this was done in the first pilot phase. And the second phase will be starting, as like I said, has already started, will be finalized by mid this year. Next slide, please. So one of the achievements was we identified an amount of the active hotspots, access the availability and functionality of the condom dispensers, which is in the 349 hotspots, 28% of the hotspots had condom dispensers. So meaning we need more dispensers in these places. We've seen people who are improvising, but we shall ensure at least we give them hotspots. And total of those hotspots received, all the identified hotspots received the condoms. So people are able to get their condoms. And this includes the consumption, like I said, by 30% in the 6 months. And also we've seen the issue of creating of employment for the youth that can handle the last mile assessment, and we track them as they distribute condoms. And the EIB last mile condoms management initiative, that we're able to track the condoms accountability last mile and identified quantified for each hotspot, which is next key in the next phase. Next slide. These are some of the images of people delivering, the people and those ones who are receiving the condoms of the one we are distributing. Next slide, please. And as we said, this was the first time of implementation. We faced a few challenges due to lockdown, due to COVID-19 that affected the movements of the riders, because movements were restricted across the district. Then when it was a rainy season, it became too hard to cross because we are using motorbikes. Then also the road infrastructure. Then we found in places where people, their languages are different from what speak. Some of them didn't know how to use the documentation so well, but training and capacitation was done. We hope next time it was better to happen. Then cooperative focal people, they thought we are taking on their roles, yet the ultimate need was to ensure there is unlimited access to the condoms. And some regions, given the cultural background, the interest was low, and there was no data to predict consumption. But this time around, we have the data, which is next slide. So in the recommendation, we are proposing to use condom consumption trends to ensure optimal stocking of the hotspots. That is by monthly, our trend to ensure this we feed them by monthly, and communicate work with the condom focal person during the distribution to ensure at least they inform their teams and they train them on how to use the data and able to report through and how when to order, and also developing a schedule for filling the hotspots, and also active demand creation program needed to enhance consumption in the districts and where to enable people know where they can able to get condoms apart from the historical distribution method. Next slide. Thank you for listening to me. That's all we have to share about the last mile. Thank you.
Thank you, Ivan, for sharing the Uganda experience. And we have a couple questions in the chat box already about your experience, which we hope to get to at the end of this presentation. But next, let's go to Mozambique. Isidio Nantambu and Jose Neves will be presenting a unique partnership with Project Last Mile and the national program, which is a unique PPP that they like to share their experience. So thank you very much.
Muito obrigado, colegas. Eu vou falar em português. Estou com o José Neves, que irá falar em inglês. Sim, é muito gratificante ver países vizinhos com problemas idênticos e que já estão a fazer coisas positivas. Aprendi hoje aqui. Nós, como país, estamos numa fase ainda embrionária, portanto, da implementação deste projeto Last Mile, em parceria, portanto, com a Environment and Technology Foundation. Iniciamos agora em janeiro. Vou deixar o José Neves, portanto, que faz parceria com o Conselho Nacional para fazer a apresentação daquilo que eles se propõem fazer aqui no país, para também melhorar a nossa prestação naquilo que é a disponibilização do preservativo até a última milha. Certo?
Okay. Obrigado, Isidio. Isidio and SSLN has been kind enough to let me do this in English instead of battling through in Portuguese. Let me tell you first who we are and how this started. We were approached by the Global Fund some 18 months ago to work with the CNCS, which is the National AIDS Council equivalent in Mozambique, to support the national strategy for condoms in the country. That strategy has three key pillars to it. The first one being around stewardship and governance around condoms in the country. And the second pillar had to do with demand creation and marketing, or increasing the demand for condoms in the country. And the third pillar has to do with route to market and ensuring distribution and better availability of condoms in the country. So Project Last Mile was asked to focus really on pillar 2 and 3, which is the demand creation side and the route to market side. And that's what I'll take you through now. We're still in the fairly early stages. So what I'm going to share with you is really just the approach that we're taking. Hopefully in a few months from now, we'll be able to come back to you and share actual results with you. So what I'm sharing now really is the concept and the approach. This project has a relatively short time frame, given the nature of the project, of just 18 months. And we started back in November 2021, and it will run through until about May 2023. So first of all, I only have I only have 3 or 4 slides. So the first slide is really about Project Last Mile and what makes this project different, and Project Last Mile different, and equipped really to take on this task to support the CNCS, or the National AIDS Council, with the condom strategy. While Project Last Mile, it started some 10 years ago, really at a discussion that the CEO of the Coca-Cola company had with Melinda Gates at the time, when the question was put on the table, it doesn't matter where you go in Africa, you can find an ice cold Coca-Cola, yet many of the critical medicines don't get to where they need to get to. So the Coca-Cola Foundation, the Coca-Cola company itself, committed to put together this project to share the knowledge and know-how of the Coca-Cola company, what makes them so effective in last mile distribution, to share that knowledge and that know-how with ministries of health in Africa where there is a need. So it is a public-private sector partnership. The Coca-Cola, of course, as I said, representing the private sector, and it initially started the Bill and Melinda Gates Foundation, and was later joined by USAID, and then the Global Fund, and more recently by PEPFAR. And there are projects running in some 10 countries in Africa now. Each one is very different. It depends on the needs of the country. And in Mozambique, I have personally been involved for some 6 years now. And it's focused more on routine optimization, on outsourced distribution, and in more recent years, at a higher and more strategic level with the Central Medical Stores of Mozambique, called CIMAM, to really help them with the implementation of a long-term strategic plan for all medical medicines and medical products, of which condoms is an item in that list as well, and also to support them with the transition to autonomy, which they don't have from a legal standpoint at the moment. So the work we've done has been quite high level and strategic now as well. We've designed a future operating model, and we're now working with CIMAM on the implementation thereof. Also, we are supporting the implementation of the long-term strategic plan for information systems to assure a better visibility of the medicine supply chain in the country. And of course, all of that work benefits to a large extent this work that we can do and intend to do around condoms in the country. So having said that, let's go to the next slide, and I'll tell you a little bit about the approach that we're taking. So really the objective is, as I said, our aim is to support Pillar 2 and Pillar 3 of the National Condom Strategy, which is increase in demand, for condoms, and then improving the supply and availability of condoms in the country. We are focused on the public sector, the government or the free condoms, though obviously to be effective in the marketplace, there's quite a lot of effort and energy going into understanding the total condoms landscape in the country. In any case, I'll just give you in these 2 or 3 slides that I have quite a high level view. I'm fortunate enough to have the experts on hand with me here today. So Amanda Mancha, who's an ex-marketing group director for the Coca-Cola Africa and Eurasia Group, and is now part of Project Last Mile. She's leading the marketing and demand creation side of it. And then I've got James Flood, who's from Frontline Research Group and will lead the route to market. And James has worked with me for many years now and with Simam on the supply chain for all medicines in the country. So there's quite a lot of knowledge that comes to the table. So first of all, the approach that we're taking on the strategic marketing side is to segment the market and profile the consumers, and also to understand the consumer journey, so that we can develop targeted communications to our an immediate strategy for the target market. I can tell you at this stage, our target market is men 15 to 24, though I know that Amanda and the team is working with other stakeholders really to define that a bit better, or work with that. But at this point in time, that's the target market, young men in those age groups. And we've contracted, in addition to having a resource on the ground, we've contracted Dentsu Create, a marketing agency in Mozambique, to help us with more local insights and development. So coming from that, we'll develop an operational marketing campaign, and that's to identify points of interaction where the consumer meets the condom in the marketplace, on the ground, and how do we place the product in the best way to encourage offtake, and what messaging do we put at that point. So that's really the operational marketing, and the objective is really to effect behavior change, because in Mozambique, it still has one of the lowest usage rates for condoms in Africa, and there's quite a lot of history and hesitancy, if you like, resistance even to condoms. So for this campaign to be successful, it's really about giving effect to behavior change communication. Right, so that's more on the marketing side, and Amanda can answer any more technical questions that you have. And then on the route to market side, it's as I said, we primarily focused on the free public sector government condoms. And we'll look for quick wins and what can be done to improve that supply. But really the secret for success is that we make the condoms more available and accessible. It's not good enough if they're only available at a hospital or at a health center. And when we were in the field just a week or two ago, the one provincial director said, you know, after 3:30 in the afternoon, condoms in the public sector aren't available anymore, because those are the working hours of the public health sector. And you know, that needs to change. If that is what it is, we need to find alternatives, non-traditional outlets, hotspots, whatever it is, but we cannot just leave it the way it is there. And then the second part of that is really to develop a picture of success that's aligned to the work done on the strategic and operational marketing side, so that the condoms are available and meet that increased demand that we hope to generate from the campaigns that we will put in place. All right, next slide. This, as I said, we have quite a fairly short month period. Okay, when we put the start together, it says 16 months. It's 18 months, but it started from November and it went over the holiday period. So practically it is sort of 16 months. And there are 3 key phases that cut across both the demand creation and the route to market work streams. The first phase is really about understanding the current reality and market segmentation, and we're deep in the middle of that, even with our agency, and our team has spent time in the marketplace already, up to this stage, really understanding the social condoms that are supplied through DKT and PSI, and also the private sector. And in our next visit, which is quite imminent, we hope to spend quite a lot of time in the field on the free government condoms. So we're busy with that in the first phase. The second phase is really, to design and bring conceptually together the strategic marketing and operational marketing side to the market framework, to bring those 2 together. And as I said, during this whole time, any quick wins that we can identify, we'll share with stakeholders to implement already. And then the third phase is ready to run, which will take, we hope to spend at least 6 months in that, is where we actually do a pilot study in the field with that. And given the time that we have, and also the budget, which is constrained to some extent, as always, in this phase, we can really just do one pilot, but it will bring together the concepts from the operational marketing side together with our route to market activities. And then the last slide, if you can go next, please. Okay, this is really just the deliverables, and I guess I won't go through all of them because based on what I've said, you would have gathered that on the create and demand side, what we've committed to do, and we on track to do with the team that we've put together and the resources, is to do the landscape assessment, is to develop that consumer journey across the priority population group, is develop the strategic and the operational social behavior change communications campaigns, and then to actually execute that in the field during the pilot, linked to the route to market side, which also aims, in addition to the pilot, of course, is to improve data visibility on the national or the public sector condoms. And again, from the introduction I gave you about the work that Project Last Mile has been quite fortunate to have done in Mozambique over many years, thanks to having James Flood on board, we have quite a lot of knowledge already. It's not satisfactory. There's so much more that can be done in terms of improving data visibility and also measurements and KPIs. And so that whole area around data is definitely one area where we hope to add some value to the national condom strategy. And then whilst we are focused on the public sector, as I said, it's important that we understand the private sector as well and the social marketing sector, so that there's no duplication, so that we work together for the realization of the objectives of the national condom strategy. And I've already spoken about the picture of success and then testing in the market. And then just to conclude, I mean, ultimately, our objective in these 18 months that we're on the ground is really to build capability and transfer the knowledge that we have and the perspective that we bring, given our private sector history that we bring to the table into this project, to transfer that capability and knowledge to the CNCS and partners, so as to make it sustainable. I mean, there's a lifespan to our project, and we will walk away and really want the knowledge and what we've learned to remain in the country. And also, as I said, we're only doing this in one small geographic area, and the idea is that whatever we do can be upscaled to the rest of the country. Okay, I'm going to leave it at that, and if there are any questions, I'm happy to take them, and I've got the team on board as well. Thank you.
Thank you so much, Jose. We have a number of different chats in the box currently right now. We're going to try and do our best to get through as many of those questions as possible. But let us tackle a few of the common themes that I've identified throughout the presentations. Thank you again to the presenters. A variety of approaches between Mozambique and the public-private partnership, and similar approaches in Malawi and Uganda. So for Ivan and James first, some questions around the specifics of your program, including how many community distributors and dispensers at baseline are being leveraged, what's the number of outlets that we're talking about, and how many are needed to make this strategy operational is one question. Another question regards data collection tools that are being used at the hotspots. I know that, Ivan, you mentioned this briefly, but how are you ascertaining whether condoms are available or not? If you could explore that a bit more. And then finally, are condoms distributed alone or with other health commodities within this distribution system? So I'll start with those three questions first for Ivan and or James. Would one of you like to volunteer to respond? How about we'll call on Ivan first in terms of the number of distributors that you're engaging, dispensers at baseline, and that data collection tool. Can you elaborate on that if you have those numbers or approximates on hand?
Yes, initially we thought of getting to around, because we didn't know exactly how many condom dispensers are in the public and their functionality. So we went looking for the exact to ascertain the numbers. But after the exercise, we found I have the figure somewhere of the exact number of hotspots. We only found 300,499 dispensers in the public that were functioning. That's equivalent in 28.7%, meaning the other close to 60% didn't have condom dispensers that were active. So, and in total, we are able to find 14,175 hotspots, meaning we still have to do some work to ensure we are very dispensers to the different hotspots, because most of them were improvising. And then on the data collection tool, we used a system-based tool which was put in this app. All information was captured through the app to allow easy retrieving. But what we did best is that all the riders, people who were doing the last mile deliveries, were trained on how to use the tool, how to capture the data. And so the information was able to come through centrally, real time. So as soon as you can easily also monitor on the dashboard, which rider, which place he has been able to see, and which place has been able to identify the picture of the hotspot. So all that information is coming through electronically, and it was real time. Thank you.
Thank you, Ivan. And while we have you, can you just describe what your dispensers look like, or what are they? Are they boxes? Are they the dispensers themselves, the boxes that the condoms came in, or are there other smaller type boxes that you've designed?
Dispenser, it's not like it is like a box that is transparent. You can be able to see the quantity of condoms inside. It is ably displayed on the wall at a point where everyone can use. In different hotspots, most of them are in the toilets, around corridors going to the toilets. So it is mounted on the wall. It has a point where someone can pick the amount of condoms they want. And it has a point where there is limited access where someone can open and refill with a key, then they lock. But leaves an option where someone can pull through condoms without inputting any digits or anything, but he just puts the condoms in it and is able to use. I will share the picture of the condom dispenser that we are using. Everyone have a clear glimpse. Hope I've explained it clearly.
Okay, thanks, Ivan. And then over now to James in Washington from Uganda. Could you just elaborate a bit more on the process that you undertook to support your mapping of high-risk outlets? How did you describe or define what a high-risk outlet was? And what was the process that you used to actually support the mapping itself?
Hello, can you come back on the question for Malawi?
For Malawi, the question is, can you describe the process that you used to identify hotspots? How did you define what those hotspots were? And then what was the process that you used to identify what those outlets were in your geographic communities?
Okay, I'll start and my colleagues can come in. Mainly identification of the hotspots depends on the population that you are targeting. For key population like female sex workers, the hotspots that we target are the entertainment places like clubs, bars, or any trading center where there are a lot of activities to do with the entertainment and the social interaction, where we see that a lot of sexual activities take place in this area. So for female sex workers, we target those areas as hotspots. And for MSM, they have their own places where they meet, and some of them are the entertainment places and the some corners where they meet as a subpopulation group. So mainly the hotspots that we have in Malawi, they are defined by the target group that we are, population target group that we are working on. But I have my colleagues, they can come in. I've also seen Dr. Masamo joined, but for now, that's the technical definition of a hotspot. Thank you.
Thank you, James. And for you and or Ivan from Uganda, again, what was the process that you leveraged to actually support the mapping of this? What type, how many people did you use? Who was doing the mapping itself? How was that information recorded and fed into the community level and then on up to the national level? Either James or Ivan?
Actually, for us, we used on average 10 people per district. And Uganda has around, that means the entire activity, we used around 500 people to do the mapping, because we may find different localities, it is hard to cross over. But in the second phase, it will be a bit easier. Yes, thank you. Someone has already displayed the common dispenser that we also use. Thank you.
Okay, great. Thank you, Ivan. We are running on time. There are a number of questions related to TMA and the sustainability of these interventions within each of your communities, how private sector is engaged throughout, which also relates to TMA, and also some issues of how do we ensure that access is translating to use, which is a great question. Ideally, we do have surveys that are regularly supported in place that do measure use, either through IBBSSs or DHSs or FIAs. There are a number of tools and approaches throughout. But we also note that in most of these countries, Malawi, perhaps the exception in the richness of data that is recent, is that we don't have great new data on use, which is really the gold standard of what we should be tracking over time. Access needs to be translating to use over time. We are going to continue this conversation next week for sure, but I would like to be sure that we have time for Clemens Benedict, who is the UNAIDS focal point on prevention overall, to say some closing remarks, and look forward to seeing you, or many of you, either virtually or in person next week. Thank you very much. Clemens, are you still on?
Thank you so much, Chris. And yes, I'm still on. And thanks to colleagues who joined this very interesting session. I think we've heard great experiences from Malawi, actually, on community-based distributors, geographical prioritization, use of dispensers as innovative strategies for last mile distribution. From Uganda, the Stockholm distribution model, from the joint medical stores, data collection system, hotspot targeting, and actually a 30% increase being reported through these last mile distribution interventions, which is very encouraging, and actually also important to use data and to show actually and track what the outcomes of last mile distribution work is. And finally, we've heard also from Mozambique on the market segmentation, strategic marketing and demand generation aspects, illustrating how important it is for condoms to be at the right places at the right time for the right populations. I think this work on last mile distribution of condoms will keep us busy and keep us engaged in developing new solutions for the coming years. We've had actually in the past often scaled models through social marketing to make condoms available in a very large number of outlets in some countries, and with funding challenges in some of the social marketing programs, some of that non-health sector access to condoms, which is so critical, has been diminished. And clearly, we need that innovation and the suggestions that are coming through fora like this one to actually strengthen last mile distribution programs and develop new solutions. And I think we need to be in the future also continue to be data oriented, really plan well, focus well, as we have seen today, and also be bold and consider how we can ensure a constant supply of condoms close to or as close as possible to where they are needed. And I think the partnership and the learnings from the private sector give us a good indication here. And I think the challenge that was quoted here to us as a community to make condoms as available on the continent as a cold bottle of Coca-Cola often is a challenge that we'll need to continue exploring by partnering, by using existing large-scale distribution mechanisms, and making sure condoms are in the bars, in the shops, in the communities where they are needed. So great work ongoing, a lot of work ahead of us, and looking forward to collaborating more as part of the South-to-South Learning Network, the strategic initiative that the Global Fund has launched on condom programming, and within our other HIV prevention and sexual reproductive health programming contexts. Thank you so much. Back to you, Chris.
Thank you so much, everybody. This concludes our webinar for the day. Hopefully it is not our last, and we will continue the conversation next week. Take care, everybody. Bye-bye. And I see we have a poll that's online. Just a few quick questions, if you could answer and submit. That would be very helpful for us to integrate that feedback into future webinars. Thank you.
Thank you.
Thank you. Bye.
Thank you.
Thank you. Bye.
Thank you. Bye.
Bye, everyone.
Bye. Bye. Thank you.
Bye-bye. Thank you.
Bye. Well, John, we're not able to promote. I've expected the items, they are in good order and in the right quantities.